My name is Hongyi Xu. So good morning, good afternoon. I hope my presentation is going to be really quick. I know either you're sleepy or you're hungry. So a quick introduction of myself. I'm a technical officer for the non-communicable diseases department at WHO headquarters based in Geneva. I'm speaking today in my capacity as responsible for developing WHO NCD service integration guidance, as well as serving as the implementation research focal point at the WHO headquarters to support this workshop and follow-up technical system conducted by University of Texas. A background of me, I have worked in the field of health in international organizations, including WHO, UNICEF, and UNAIDS for around 15 years in countries and regions in Asia and Africa in various areas such as health system, monitoring evaluation, and health information research and non-communicable diseases. I moved back to WHO headquarters to the NCD department in 2018. So the presentation today is about NCD services integration and how implementation research can help. So we talk about integration. So what is integration? The WHO working definition on the integration is about the organization and the management of health services so that people can get the care they need when they need it and in a way that user-friendly achieve the result. And of course, we want to provide value for money. So where we are now, in some settings, when we talk about the integration journey started as integrating comprehensive services to certain conditions. For example, diabetes. This is including a preventive behavior change, medication or patient follow-up, and community service all together to provide the needed service for the patient. In some settings, when we talk about the integration, the journey is about the integration of services for different diseases or conditions, such as the services used to build it up for vertical program for HIV/AIDS. I think we already have the colleague mention those examples, and our colleague from Nigeria also mentioned this. So we want to integrate that sort of services designed for vertical program in the past, now be leveraged the experience and resources for NCDs in those countries. In many situations, the integration journey is about integrating NCD services into the primary healthcare health systems. So in a way, we know that the concept of integration has different meanings and different applications across services, across system, cross program, across settings. But we do find in our guidance, there is 3 typology of integrated care are really relevant to the situation in lower middle income country. What we call the 3 typology, one is on the functional integration. The functional integration basically talking about this is involved the back office and health system support functions and activities. For instance, health financing, for instance, medicine. And those systems, how to structure and integrate it around the primary process of the service delivery. So in a way, this is related to our previous speaker when they're talking about the building blocks. The building blocks are still important, but the important most important thing is about it should integrate those health system function and looking at the health system configuration so that the NCD service can be provided. And our previous diagram, you already see what is the service integration. This is referred to integrate, coordinate the different health services. Although most time we talk about clinical service, we want to coordinate at organization level, but also across the different level of health service delivery platform. For instance, coordination across health center, across community care, and across the first level hospital, the district hospital, mostly in the situation of a lower middle income country. So now we're talking about the NCD integrated service model. What do we really know right now? And firstly, we had a review recently working with institutions based on University of Harvard. We try to looking at all so-called service delivery models in all lower middle income countries. So basically 44 countries, we collected a study around more than 180 studies. We try to identify what is the common pattern when we talk about the integration models. And one thing is actually exactly that many of colleagues already know that we're talking about the new conditions integrating into the existing delivery models using Marian language is basically we're talking about, we want to integrate the things worked for the new condition. We want to deliver those things using the existing platform. So that is one of the common type, we call it the integration models. But we also single out another type of integration is basically talking about new care delivery team. So what is this exactly? This is a case study. It's actually happened in Rwanda more than 10 years. Now, the similar model also try to implement in countries, for example, Malawi and Liberia and Haiti. So this model basically looking at two levels. One level is the traditional health center. And this model set up the services in the health center, be able to conduct the basic health services for the common NCD diseases, for example, hypertension, diabetes. But this model also looking at the second level of care, looking at the district hospital, the cost of building such a model in 10 years, the capacity required. So from this model, we can say the startup cost for building a so-called PAN plus integrated NCD service model in a country like Rwanda, startup cost will related to 48,000 US dollar, and then the annual operational cost would be around 69,000 US dollar. And this model, including a range of the health workers, including the nurse, including the physician, also including the lab technician and other supporting staffs. And the capacity of this clinic, it would be able to provide a range of the NCD services covering common NCDs and a severe NCD for catchment population of 300,000 population. Would be able to serve a enrolled patient in around 600 per year. We also have another review. This review really just focuses on the community-based model of care for treatment hypertension in sub-Saharan Africa. In this model, two important things are coming out. One is related to the information system as well as telemedicine as sort of innovative way to deliver the service and to using the community forces to deliver the service. And another thing from this community-based model is we have a detailed findings on what is the component of the care in terms of community-based service model. And that's related to few service, for example, related to medicine delivery at the community level. And this also related to how to achieve the treatment goals using the community forces. And the further element related to integrated with other chronic conditions, for example, HIV/AIDS services and the transfusion services. One second, I just adjusted. So this slide, we are talking about the WHO NCD service integration guidance. The full title is Guidance on the Inclusion of NCD Prevention and Control within National Responses for HIV/AIDS, TB, Reproductive Health, and National Program to Strengthen the Health System. So the audience of this guidance is policymakers, program managers, health providers, but also we want researchers like you to help with implementation research aspect. So in a way, it's through continuing looking at the implementation research of evidence, we'll be able to use this evidence to shape our guidance. From this guidance, there are 18 recommended actions fall into 5 domains. The 5 domains are people and community, policy and leadership, financing, capacity infrastructure, and model for care. So when we're talking about this 18 recommended action, this is almost related to Dr. Rahit, our previous speaker, mentioned what is change solution like. So this is change solution like if we would like to the NCD service integration in the lower middle income country works. And on the model of care, the recommendation is about designing models to make sure new services are feasible and acceptable through the delivery model. So this is also relevant to the implementation research. The guidance identify the key steps in integrating of NCD services with other programs. So we do have the first step, prioritization. We ask the researchers to help the country analyze characteristics of the existing service platform and to look at the global and national clinical guidelines to know what are those effective interventions. So what are those things? And then to check the feasibility and acceptability factors and design and redesign the model for care according to those parameters. And integration, importantly, conducting implementation research including the process evaluation. So in a way, we want the implementation research happen side by side along the model design and implementation. This is just a snapshot on a list of interventions that may facilitate the intervention, for example, between communicable diseases and non-communicable diseases. We single out tuberculosis and HIV/AIDS for the settings that really have higher prevalence of TB, have higher prevalence of HIV/AIDS, but also meanwhile have higher prevalence of non-communicable diseases such as hypertension and diabetes. And there are parameters to be checked. So some of the colleagues already touched on this, and this is just an example to show that the parameters, for example, related to feasibility, what we want to know feasibility, we do want to know what the resources are available or not, and if not, how we can get the resources for the service that we want them to implement in the setting. And if there is a capacity issue, and if training required or not, and how the training can be tailored to this situation. So remember, there are many entry points for integration. Colleagues sometimes mention, okay, you know, there are some donor preference in the past, but there is also changing opportunity that even we can working with our traditional donors to find a way and to looking at that non-communicable diseases treatment and prevention service can be provided through those window opportunity and including financing opportunity as well. And we also encourage the country to looking at the innovation way. I talk about telemedicine and information system, and in African context, we're also asking using the efficiency lenses to see how we can actually maximize the available resources for the need of the patient. So this, I skipped this one here. So this slide, at least some of the research gaps, and including the implementation research gap, which have been identified through the guidance. We believe failing those research or implementation research gap will not just have provide evidence to policymakers to your own individual country, but also generate evidence and good practice across the broader research community in different countries and region, and help us WHO with more robust evidence shaping our guidance and also our NCD integration agenda in the future. This slide, there's just some published protocol. This published protocol, we leave it here. It's for your reference. Some of them may have, you know, good research question and good implementation strategy on the NCD prevention control to their own setting. Some of them actually utilize WHO existing guideline to their situation very well in the country, for example, Kenya. And the last slide is show you the research and network. And if you want to know what is more resources or opportunities, even including some capacity building and grant opportunity through the WHO network and for you to use. We also have a good network of WHO collaboration centered, and some of them already have similar research experience in some lower middle income country, and you can easily find it from those links I provided below. So I stop here and thank you very much. Back to you, Cedra Monitor.